you put also your finger on a challenge that I face on a regular basis, which is how do you frame a national study? How do you frame national work?
We are proud to announce the launch of our podcast by taking the time to speak about an important topic, mental health. As Canadians have been under lockdown mandates for months, one organization, Mental Health Research Canada, has been tracking and monitoring Canadians' mental health. The numbers are staggering. According to MHRC's latest poll conducted on mental health during COVID-19, Canadians are reporting their highest levels of anxiety at 23%, depression at 15%, above the levels at the peak of COVID's first wave. Moreover, MHRC discovered a potential relationship between social distancing compliance and mental health. Those Canadians not adhering report higher degrees of negative mental health due to the economic downturn resulting from COVID-19, 56% to the overall response of 44%. That challenge has to do with mental health awareness. And if you want to hear how Michael Cooper, the Director of Development and Strategic Partnerships at MHRC, approaches the issue, tune in for the rest of our discussion. So what is the best way to, as a health organization, I would almost consider MHRC as like a think tank in a way, a mental health think tank. Yeah. How best do you do it? Because there's limited resources, there's limited time, and there's massive issues. And so,
right. Like, well, obviously, we've been advocating. Yeah. To answer your question, what we've been advocating for is that what we're primarily working on right now is pan-Canadian population. So things that will give us a general trend lines as to what's happening in Canada, what's happening in age groups, what's happening in major population things that are vast numbers of people, visible minorities. We can track by immigration status, those sorts of things we can track by. But what we've advocated for is that should be the start of a system that Canada should have had a long time ago, which should be better tracking of mental health data across Canada. You have someone like CIHI and those sorts of organizations that are really good at collecting health-related data from things like, so if you break your arm, you'll go to the doctor, right? And the government will know that because they'll have a record of your health card number and that. But if I have a mental health need and I have anxiety troubles, there's a reasonable chance that I'm going to go to my insurance provider and I'm actually going to access private resources for those sorts of things that will never be tracked through the public health system. So we have huge gaps in data here. And the position we've been taking is that this work is especially necessary in the pandemic, but it needs to be built upon when we're done this pandemic because we don't have good data. Like even the commission's own work on what's the scale of the problem, a lot of that stuff's 10 years old or older. We don't have up-to-date data. We don't know what's happening in any given year on a massive scale because the data is spread between public sources, private sources, and a million other sources. So to answer your question, I think that we need to do work like we're doing on an ongoing basis, but I think it needs to be supplemented by different methodologies that are collecting data on samples on what's happening in those specific communities. And I think those data sources need to be correlated in a way that's, scientifically valid and valid from a data perspective, so we can have a better sense of what's going on and tell the story of what's going on a macro level in Canada.
Right. Because it seems like mental health and mental health data collection sort of at the far end of the bell curve right now, it's just the beginning of this massive wave that's going to come for looking at the issue in a non-stigmatized way and actually talking about it openly. Whereas before, 50 years ago, people really didn't talk about this. And that's why, I guess, I don't know what your perspective is, but every time when I read books, a lot of books now in the United States focusing on higher levels of self-harm amongst young children, especially social media addiction and those kinds of relationships.
Yeah.
A lot of them are saying that there's skyrocketing rates of depression and anxiety, but I don't know what the benchmark is, as opposed to, are we just finally talking about issues, or is this a really cresting issue?
Right. So you're also coming across the fact that there are massive numbers of people who are undiagnosed. So when we ask young people, for example, have you been diagnosed with anxiety or depression or any sort of other sort of major mood disorders, we get a dramatically higher number that are indicating, I have to go back to my notes, but you'll find it in the reports, but it's probably a good 6 to 8 to 10% higher than the general population. And what's fascinating is we also apply the Kessler 10. So we're trying to look at their symptoms to try and understand how well we correlate. There's a couple different models. There's another one called the RAI, which tries to correlate mental health. StatsCan did some work on this. So the problem is you've got really three different things here. You've got self-rated mental health, which we're capturing. You've got previous diagnosis, and then you have a large volume of these people who've probably been told that they have depression from a guidance counselor or someone along the way that has not actually classified them or not actually put them into the system as as having, depression or an anxiety disorder. We know also that some of those things, for example, are treated with better resiliency training. Some of these youth are struggling with anxiety, but they just haven't developed those anxiety skills yet. So this really comes to a question of what is an anxiety disorder? At what point is it diagnosed? At what point is it permanent and not actually adjustable? Because my kids have anxiety when they're 5 years old, but that doesn't mean they're going to have anxiety, 2 years from now. It's a temporary state, right? So that's a moving number. And what I would say is I do agree that more young people have anxiety than other populations. I've seen the numbers. I've run the math in terms of how well we can correlate self-rated mental health against that. But I also think that they're showing high degrees of resilience, or that they're recovering the resilience, or they're building resiliency training. What's really fascinating for us is we take the number of people who self-rate mental health. We look at an average number of score on a Kessler 10. So what symptoms are they actually doing? And we try and merge those two together. And then we also look at it for, do you have any hope for the future? Do you believe you're going to bounce back? Because, right now we're in the middle of a pandemic. People's mental health is really struggling. And so the fundamental question for me is that going to last? Like, I'm depressed because I don't get to go out all the time, but I'm not going to be depressed once I get to go to Canada's Wonderland next year. So how much this question gets complicated because you get into the question of what's temporary, what's permanent, what's normal for a situation, and then what's abnormal and going to sustain itself. So, we've been sort of looking at the numbers and saying we're generally concerned about 18 to 20% of the population, which is overrepresentative of young people. We're less concerned about seniors, which everyone talks about seniors all the time. We're less concerned about it because not only are they demonstrating lower rates of high depression and anxiety in our work, but they're also demonstrating significantly higher degrees of long-term resilience. And also the economic anxiety just isn't there as well too. So there's a bunch of factors that make me think that yes, young people are struggling more. It's not to the degree of which I think that some people will outgrow that, or that I think that some people will actually move beyond that. I do think that's going to happen. I just question how bad the pandemic is going to be in terms of taking some of those people that might move on or might grow, and then now they're stuck, right? And they're not going to be able to develop some of those coping skills because during a critical development period, they're kind of getting screwed.
Exactly. Well, I guess that brings me to the question, which I sort of have been thinking about, and I feel like some people have thought about it, but have had trouble articulating it. But how do you balance, or from your perspective, it's sort of in self-isolating and in ensuring that there's social distancing, we're protecting certain percentages of the population which are high risk, but we're also sort of shifting in some way the stress and the anxiety onto a larger set of the population, perhaps that may now become vulnerable as a result of that. So it's a very tough situation, right?
I agree with you wholeheartedly. I mean, you're balancing the physical health risks against the mental health risks of another population. There's no, you have my support in that belief.
We just wanted to take a moment to thank you for your continued support. All the donations received will be going towards Canadian mental health charities. If you're feeling in the giving spirit, check out Speakeasy's donate tab to throw us a little love too. Some of the statistics that I was reading in the third report that you guys had released recently on some of the COVID-related data and the higher levels, of particularly amongst people who feel sort of depressed and anxious to not adhere to COVID regulations and restrictions, are very...
That's fascinating for me.
It seems, I'm not sure what statistical word you would use, but it seems decently correlated, or at least in some ways, a relationship there.
There was something weird in there that was like we were looking specifically at people who rated themselves, and again, that was 2 polls ago, so I have to go back in memory a bit here. But there was something in there that was specific, like the number of people who indicated 10 out of 10 on depression, who were also not adhering to social distancing guidelines, was significantly, it was like 700% different. Like it was a major difference between those two groups. And what's interesting in data collection is you get something like that and you're like, well, that's weird. Like it's something we can validate, and we then go back and when we run the data again for the next poll, we'll check it again to make sure we weren't far off. Sometimes it'll move a little bit, but not big. And then you're left with this conundrum to say, like, why does Why does that happen?
Yeah.
Why do we think this has happened? And then you get asked that question all the time, and you're like, well, I can tell you that it's happening. I have to imagine why it's happening. The why, I don't know. The why, I could imagine that there are probably groups of people who are generally struggling, really struggling. And the idea of putting a mask on top of all their other struggles is reality. I do not think that mask wearing and depression are correlated one-to-one.
Right.
I imagine there's some third thing here that's jointly influencing both categories, that there's some sort of correlative, be it that they're barely holding on, be it that they're a generally pessimistic person. So that's the why. I have to sort of imagine the why, because there'd be 1,000 whys, and then you have to figure out why, what's the commonalities between these things. And it's certainly worth asking. I don't have the answer. I can tell you it's true. I can't tell you why.
Right, exactly. That seems to be the question, because I know a couple of close friends who also have trouble with social distancing, and sometimes they entirely sort of try to avoid the regulations and rules. And it's funny, again, they fall into that category. I would say they're definitely in the category of economically insecure and probably socially predisposed already. And so as you're saying, you're probably getting associational attributes. You're sort of getting at someone who prior to the pandemic is probably somewhere in a precarious employment state, who maybe doesn't have a lot of social or support networks. And so when you start pulling on those strings, then it makes a lot of other issues come to the front.
Yeah. People who might be economically or societal or emotionally fragile can't take that. Like there's lots of theories as to why. And, our data says that these people are depressed and they're not wearing masks. And so once we get enough data too, our hope is what we'll do is we'll go back and we'll say, okay, let's take a look at 5 polls worth of people who said they're not wearing masks. And there's 10% in each. So there's 10% of 2,200 people times 5, because you got 5 polls worth. You get 1,000 people in that group, right? And then you start picking apart attributes inside that group. Okay, so we know they're already more depressed than the other group, but what else can we pull above them? So we see that the group that's more depressed, maybe they're also younger. Maybe they're also, because what we have in each individual poll is a snippet, a tiny little bit. And then what happens after a while is we start aggregating data together into a combined data set. And we didn't know we were going to be able to do that. We got to be able to do it because we don't see mental health moving as much as we thought we were going to get in the pandemic. Like it got really bad, and then it's kind of just mildly moved up, slightly worse.
I see.
So as a result, we can take all that data, put it into a big ball, take out the chunk we want, and then we've got a chunk that can be analyzed. And so our work is to keep collecting this data so that we can get massive overall samples, so that we can hive off people like the people who aren't adhering with masks. And we can say not just we found depressive, but we can also say we're correlating them with economic anxiety. We did correlate them already with economic anxiety, by the way. But we can also look at what employment they're in. Are they in retail? Are they in hospitality? How long have they been working? There's a million sort of things we can start picking apart, and then we can create this archetype. But the problem is we're doing it in real time, picking out what we can, because we're trying to feed information to policy people. And then there'll be all this fascinating work we can do at the back end once we get enough data. But you see, so it's like kind of like a chicken and an egg situation.
Well, I guess that's another question, is really what are the benefits of employing big data into mental health? Like obviously we're going to get stronger demographic profiles of individuals. But I guess if it was in the ideal situation, let's say in 20 years, where these were actively tracked and that there were sort of no conflicting jurisdictions, and then there was open information sharing, what would you ideally like to see for the next generation of mental health care providers and government officials? Like, what would they be able to inform the public and prevent?
Well, I think one of the things that's really interested us was understanding the scope and scale of the problem, because I think you're not going to deal with that until you understand the scope and scale of the problem. You understand what groups, for example, talking about younger Canadians, are more at risk and why they're at risk. Is it that they're don't have the resiliency skills, or are there fundamental challenges that are inherent with being young, getting your first job, these sorts of things? Like how do you correlate those two separate variables? That's the first thing. Is I think we want to be able to collect really good information so we can understand the areas that we need to improve on as a country. The second thing I think that's really important is we are collecting, and we don't report on this as much, but there's a lot of data that we have on how people are engaging with their services. So, for example, we know people with a previous diagnosis, like 60% of them were saying they're primarily managing with medication. But we also know from talking to our internal working group that far more people should be getting talk therapy or some sort of a response where they can actually engage with people. Yeah. So we can look in our data and we can say, like, okay, we know that X number of people are getting medication, and we know a smaller number of people are getting talk therapy. And we can say that if you're a visible minority, maybe you're being over medicated, your treatment's being dramatically over medicated. And maybe if you're a rich white guy with benefits, you can get, and I'm just creating a hypothetical here, so I wouldn't quote me on this, but like there'd be different, that we can actually start pulling apart who's more likely to get this talk therapy and who's more likely to get just medication, which isn't helpful. So I think it'll help identify where there are gaps, because a lot of times people have theories and stories and anecdotal evidence of gaps, but we want to create categorizations of where there are gaps in services. The other thing that would be really great is we're accessing Canadians and we're talking to them about virtual mental health care, because we know that we're not going to be able to solve, I think everyone sort of has to agree eventually, that we're not going to create enough doctors, psychologists, et cetera, to solve the backlog of mental health care that we have in Canada.
Yeah.
So we're going to have to find alternative means where we can support between virtual means or partial virtual means, or other apps that people can do, or activities they can do on their smartphone. Like there has to be some sort of alternative. There has to be some sort of alternative that's integrated into the fabric of how we deliver services. It's not like physical healthcare, where if I have a broken leg, I can't consult my laptop to get treatment. I can consult my laptop to get mental health treatment. So I think we have to embrace the benefits of mental health care, that we can do it, and the uniqueness of it, and actually start delivering that. So we're collecting a lot of data, and a lot of that doesn't get released to the public because it's not really pertinent to the public. It's pertinent to mental health providers. And I think a lot of that data is really cool too, because we're able to identify where people are saying their gaps are. Do they not? Thing people hate the most about virtual services is privacy. Nobody trusts talking to a computer, even if there's a person on the other end.
So what, I guess then with this, it seems that it also has become a very large project. And I know there's a board of directors and there's also academics on the board of directors, or at least cooperating with the organization. What is that relationship like? Is there a lot of integration of the latest academic literature? What type of academic to organization pipeline is sort of going on there?
Well, we're very fortunate to have our board is comprised of both academics, but we also have people who care about the mental health care from the corporate community, from ATB, the person who oversees Watson Health or works on Watson Health with IBM's on our team. So we look at it from a broader perspective than just the academic community. Our always concern around that is, although academics are very important, you want to make sure you're balancing that with something practical. And something that's going to have really applied work in the short term. I have to tell you, we have a working group from our board that goes through all of our poll data that we work on. So our board is actively engaged in this, and provides us. We're talking about the why earlier, right? Like I never come to the board or the working group with the why. I tell them what our data says, and then they come to me and they say, well, okay, let's take a look at the why. And then they'll have a conversation to understand the why, because I'm not a mental health professional. I'm a data guy. I know probably as much about mental health as you do. But maybe you probably know more. I don't know. But I'm a data guy. And what I do is I rely on that expertise. I rely on the expertise of the board. I rely on the expertise of the people who are kind enough to give us consultations. But more so, I rely a lot on other organizations, because we collect this data and then we take it out to the commission. We take it out to the researchers who work with Canadian Mental Health Association. We take the data out everywhere. And before the public sees it, I've already sent it by a bunch of people, especially to understand that why. And I storify what they tell me is the why, because they're the experts.
Is there a consensus over what is driving the why, or is there a lot of different, obviously it's a very complex issue, so there probably are competing ideas and different, or maybe hypotheses about this?
So generally there's consensus. Generally there's consensus, because sometimes it's easier to understand than others. And other times you embrace the competing consensus. Like if I were to say, why are people who are depressed are also not wearing masks? it's probably not one thing. It's probably two or three things. So you embrace the divergent theories and see if there's a cohesive story. And even if there isn't a cohesive story in that, when you present it, you say, I've heard several competing theories as to why this could be true. It could be this, it could be this, it could be this. And they're all valid theories. And ultimately, once we get enough data, we'll have a better chance of actually answering as to what the specific is. But as we are in real time and we have like this period of data set to this point, this is what we know.
I see. It's fascinating. Like it feels like you're sort of at the beginning of a very large mountain in a way. And I'm very curious to see how mental health research and the overall practice is going to be evolving over the coming decades. And beyond the long term, like I guess in the short term, obviously we don't know. We're recording right now in January of 2021. So we don't know exactly when we will see the light at the end of the tunnel. But what are like the sort of the big priorities or the major concerns for MHRC for the coming couple of months when it comes to COVID and sort of, you said there was sort of a flatlining of the depression anxiety rate relatively, or not a major increase in it. Is that something that you see stable, or is that going to be a very dynamic?
You know, I've sort of learned through this project to prognosticate less, because I was certain when we ran our second poll in August compared to April of last year, which was the sort of dip between the waves of the virus, I was certain we were going to see a dramatically decrease in anxiety and depression, which I didn't see. And I've been really surprised so much that I've sort of learned not to trust my own judgment on this and to sort of hold back my own judgment on this. My thought is, after seeing this for so long, it's going to slowly decrease over time. I think we're going to see it going pretty flat for the foreseeable future. We have another poll market right now. We are doing a lot of interesting work trying to correlate it with vaccine acceptance, vaccine hesitancy, which is fascinating, because our last poll, we were one of the first ones to do any work correlating with vaccines and how people were feeling about the vaccine, especially because we did it in a non-binary way. We asked, whether or not you were super excited, kind of hesitant. The vaccines of the devil, kind of hesitant. So that's what I think. But I'm also really interested to understand more about positive mental health states. Like, some of the best pickup we've gotten has been looking at the positive things that people doing, like going outside. We see, for example, that going outside was about 4 times more effective, like 400% more effective than being on social media. So what my hope is that we'll be able to really focus on those messages, which are less about the negative things that we're feeling. And also, we want to perpetuate that positive forward momentum that we think we're going to get coming out of this pandemic, that we'll see that we survive this, that we learn good habits. So hopefully we'll be able to discard the bad habits we picked up along the way. But I'm really excited to keep trying to find those little nuggets of positive stories, because I do believe that you perpetuate the message, right? So I want to keep putting out positive messages, like go outside, get fresh air, get off social media, stop consuming the news so much. Those are the things that we're seeing as most negative and most positive, most negative. So that's what I want to perpetuate going forward, because I think that'll help not just track the recovery, but also support the recovery, which is important too, right?
Well, that's something which I've always been so fascinated by, because I've read a lot of books like The Coddling of the American Mind and some work by Jean Twench, who's in the US, who does work on social media addiction. And it's fascinating that there seems to be such a statistically strong negative relationship with social media and smartphone addiction, especially amongst younger generations or younger cohorts. And it's something which is sort of an unquestioned thing, that children or young people should be getting phones, and they should be sort of immersed into this world at a very young age. And you don't get that alternative messaging about what you're saying, which is go outside, go camping, go hiking, whatever, like to get away and unplug from that virtual world. And it's something which I think we're missing. And it's funny, I'm sort of glad I'm hearing it finally, because we don't really hear that often.
Well, the truth is that in our everyday lives, we were forced to go outside on a regular basis. We were going to school, we were going to work. And now no one's forcing us to do any of those things. I mean, we're working from home, we're schooling from home, we're doing all these sorts of things in a lot of the country. So I think that we were being protected a little bit from our phones and from some of these things by nature of how we were living our lives. But now we don't have that luxury. So you have to do a concentrated effort
Right.
to actually do those sorts of things.
Yeah.
And this is me speaking as someone who's seen the data that going outside is important. But again, I'm positing from my own experience that I don't have I'm not forced to go outside like I used to. I don't have to go to work.
Yeah.
I can work from home. My kids don't have to go outside.
Yeah.
So my life is much more connected to screens now. And I know it's not good for my health. So you have to make a concentrated effort. That's the only way you're going to do it.
We also want to take the opportunity to thank Michael again for chatting with us this week on the Speakeasy podcast. You can find more about him and the work he does at mhrc.ca. You can also follow us on Apple Podcasts, Spotify, and Google Podcasts. Your support always matters, even if it's not financial. By liking, subscribing, and rating our podcast, you'll help us continue on our journey to grow Speakeasy as the home for compelling thought. Lastly, we are always eager to hear listener feedback, so please message us at editors@speakeasy.ca. Speakeasy, speak free.